Well, thank you, everybody. This is Allie Orwig. We're going to give it just about, well, nope, it's 12:02 on the dot. I was going to say we're going to give it just another few seconds to let everybody get logged in, but I see that it is time to get going. We do appreciate you all being with us today. I know you have a lot of priorities and a lot of things vying for your attention, but we have a fantastic presentation for you guys today from Kristen Ogden. Kristen, if you want to go ahead and start sharing your screen, I'll finish up my housekeeping items. If you do have questions today, we ask that you hold those to the end, unless otherwise prompted. We will be checking the Q&A and chat functions, which you can access by hovering your mouse either at the top or bottom of the screen, depending on which view mode you're in. And we'll keep an eye as questions come in. Again, if you do hold those to the end of the session, you will also have the option to use raise hand. Again, hovering your mouse either at the top or bottom of the screen. And we can unmute your line and you can ask that question verbally if you prefer. We will record today's session and have this available by the end of the week on our YouTube channel. So if you're not able to join us for the whole time, or if you would like to share it with some of your colleagues, we are very much open to that and like to encourage sharing as much as possible. Without further ado, Kristen, I will go ahead and turn it over to you.
Allie, thank you so much. And thanks everyone for joining. I'm honored to be here to talk to everyone in Indiana. I'm actually hearing that you all are having some severe weather right now. So I hope everyone stays safe. And anyways, thanks for joining. So my name is Kristen Ogden, and I have just recently, well, I say recently, boy, this year has gone quickly, but within the last year, I have joined the compliance team as the Director of Quality Improvement. And specifically, I work very closely with Kate Hill. Some of you probably know Kate Hill, with our patient-centered medical home accreditation program. So that's what I'm actually going to talk to you about today. But before I do that, I want to give you just a little bit of my background so you can understand my relevance in your world, in the rural world and community. I came to the compliance team from an organization in Southwest Missouri where I was there for 15 years. And as I'm sure you all have done, wore plenty of hats, as we do in rural. I started out as a floor nurse in the hospital, did some ER, managed our infusion clinic, and then I went into our rural health clinics and fell in love with primary care and rural health. There is where I met Kate at NRHA conference, and I heard her talking about patient-centered medical home. We had started the journey with patient-centered medical home with another accreditor, and I was having some struggles. But when I learned about the compliance team's program and the way that it was written by nurses, and it was specifically written for rural health clinics. It was just like I heard angels in the background singing. So we went through that journey and we became accredited, and we were able to take that to our payers and let them know, hey, we are an accredited patient-centered medical home, and what does that mean? So we were able to, our Medicaid program specifically gave us a really great per member per month to case manage and care coordinate with these patients. So there's lots of opportunities financially out there for the accreditation and or recognition. But that's what I'm going to talk to you about today. But our objectives are, we're going to define quality. I'm sure most of you have an idea in your head what you think quality is. I want you to be able to understand the PCMH model of care by the end of this call. And also I want to just give you some takeaways on how you can stay current in the ever-changing healthcare field that we are living in. So let's get going. So to define quality, it says the standard of something is measured against other things of a similar kind, the degree of excellence of something. I learned a new word. The word that I learned is lagniappe. It is a French Cajun word that means above and beyond measure. It's a gift given to a customer by a merchant at the time of purchase or service. So isn't that really what we're all trying to do? We're trying to go above and beyond for our patients and provide this excellent quality care, resulting in better outcomes, smarter spending, lower costs and healthier populations overall. CMS Innovation Center has a vision, and their vision is a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. So the goal by 2030 is the year, all Medicare fee-for-service beneficiaries will be in a care relationship, so an accountable care relationship, and then the goal for Medicaid beneficiaries is the same, that a vast majority of those patients will be in an accountable care relationship. But really, how can we do that without all the burnout and resistance? So that's really where PCMH comes into play. And there's lots of challenges in this ever-changing world from this transition from quality from quantity, fee for service into quality. And so I know that a lot of the struggles that I faced in my practices were, of course, everything you can see on the screen. Your EHR maybe isn't the best that it could be. You've got a lot of issues with that. Maybe provider or staff buy-in, staffing. Who isn't having staffing shortages right now? I know that is a national problem that we're seeing in all of our clinics. Money is always a barrier whenever it comes to hiring new staff or implementing new processes or technology, and then burnout. The last thing we want to do is the good staff that we do have still standing in our clinics after COVID. The last thing we want to do is burden them with a bunch of new processes and check boxes and things like that. So really rethinking patient-centered medical home. And I'm going to define what patient-centered medical home is, but the first thing I want to say, anything that's taking you away from your patient or patient care is going in the wrong direction. And I know there's a lot of requirements out there for documentation and just a lot of things that are hanging over our heads, but really that patient that's right in front of you and the population that you serve, that should be the very most important thing. A lot of PCMH programs are very data centric, where you have to submit quality data every year and screenshots and reports and spreadsheets. And really that's great. And it proves a lot of quality behind the scenes, but how are you taking, like I said, care of that patient and that population right in front of you? Primary care should be the center of the patient's healthcare, and it should be the hub. So our primary care practices should be the hub of our patient's healthcare. And really what matters most, I think that is the most important thing. Are we talking to our patients, and are we looking at our communities and saying what matters most to our patients and how can we meet them where they are? So this really is a winning approach for all of our patients, our staff, and our clinics. So what does patient-centered really mean? PCMH is the groundwork for a lot of different things. And like I've already mentioned, this ever-changing value-based world and ACOs and all of that, PCMH is truly the center of that because it focuses on coordinated care, what matters most to the patient, communication, the right care at the right time at the right place. So important. Focusing on prevention as opposed to, that Band-Aid approach, being proactive instead of reactive, and treating the whole person. So taking a look at maybe social determinants of health and things like that. That is truly what patient-centered should look like. And that is what the patient-centered medical home model supports. So I think Winston Churchill, he just looks so grumpy here, but things do not get better by being left alone. And I know sometimes you clinics and you managers and nurses and providers, you're all running around and you're trying to do the best thing and put out fires and just sometimes in survival mode. So it's really hard to adopt anything new, but you're not going to be able to make those changes and become better and provide better quality until you really look at different models and figure out a way to make those changes. Get rid of that grumpy guy. So PCMH truly is a journey. With your RHC regulations and standards, it's very black and white. you've got to be compliant, right? Patient-centered medical home, it's just continuous quality improvement and continuing to search for those opportunities to better take care of your patients. So I want to emphasize that patient-centered medical home is not something that you will probably ever really be finished with. It is an accreditation that, yay, I'm accredited, but the work doesn't stop. And so it's just, like I said, that continuous quality improvement. So I always say that PCMH is the icing on the cake. So you have your rural health clinic standards and the universal and specialty standards, and PCMH sits on top of that. So a lot of you are functioning as an excellent rural health clinic. So just adding that icing to your cake and being able to say, we are a patient-centered medical home. What does that mean for our patients? What does it mean for our community? Being able to market that you're a patient-centered medical home and that you've met these standards and that you really have put the patient at the center of your focus. This is a very brief overview of our standards. It's a summary of our standards, but I put this slide in here because I want you to know that if you are a rural health clinic, these are the standards that you must meet to become a PCMH. It's really not as bad as you think. It's really more of a concept. And so we're gonna bust into these standards a little bit. I know you're all on your lunch break, so I'm hoping to give you a few minutes extra, either for questions or for you to scarf down some lunch. But I do want to break into these just a little bit so you understand how PCMH can transition and transform your practice and culture. So number one really focuses on that team-based care, everyone working together to improve that overall care and functionality of the clinic. So who's on the team? Well, number one, your patient's on the team, right? Your patient should be the MVP. But the other team members should be nurses, your MAs, your receptionists, your providers, pharmacists, specialists outside of the clinic. So your team doesn't consist of just the people inside the four walls of your clinic. You have to think of your community and everyone else that's involved in that patient's care as the patient's team. So that could include, like I said, pharmacists, community health workers. You get the point behind that. I put this in here because I feel I am a huge fan of the huddle. I don't know if any of you in the clinics are doing a morning huddle or an afternoon huddle, but they can be so incredibly effective to get the day going, to make your day more efficient. Everyone knows what their roles are, solve some problems before the day starts, give a little encouragement. So I'm a big fan of the huddle. And this is just something, I know sometimes it's hard to get started with huddles. You kind of meet and you're like, okay, now what do we talk about? What do we say? Are we talking about what everybody had for dinner last night or the game that's coming up? What are we talking about? So I developed within my practice a checklist. So it kept us on task. We knew what we were going for. We stood up the whole time. Nobody gets comfortable, right? Because this is usually right before our day starts. So usually about 7 to 10 minutes, we're standing there. We've got the schedule and this huddle checklist printed out right in front of us. We are going to look at the patients that are coming in, any kind of special needs. Are there interpreters that are needed for the patients? It looks like Mary was in the ER last week. Do we have those records? Oh, it looks like so-and-so was supposed to show up for a lab that didn't happen. So we'll need to get those labs drawn. Anything like that. So you're going to review your schedule. You're going to review your staffing. Who's here today? Who's not here? Who's not feeling well and may have to leave early? Who's doing what role? Doing callbacks or rooming patients. So just getting the day in order first thing. I've also seen it to where huddles are done over the noon hour. So like right now, you guys could huddle for your afternoon session and then tomorrow morning's morning session. And then of course, tomorrow at noon, you would huddle for the afternoon and the following morning. So it can be whatever you want it to be. It could be last thing in the day to huddle for the next day. Make it what is best for you, but try it. I challenge you to try the huddle. End on a positive and encouraging note. Tell a joke or give a shout out to someone or to the whole team. But it really does. It makes such a huge difference in the way that your day will go. PCMH 2.0 is all about the P-CHIP. So I don't know if we have any nurses in the audience right now, but I'm an RN, and what I think of whenever I hear the word care plan is late nights, early mornings, figuring out how to write this big, long, convoluted hospital care plan. Well, that's not what care plans are really anymore. Possibly in the hospital, that's what we're still dealing with care plans. But this is really, I love how they've renamed it. The compliance team nurses that wrote these standards years ago, Sandy Canale is our CEO owner. She is a wonderful human being, first of all, but an excellent nurse. And so she liked the idea of changing that that term from care plan to P-CHIP, so patient-centered health improvement plan. And that's just what it is. It is a care plan, but it supports the patient. It gets them engaged. We want to make sure that we are addressing what their needs are and considering any kind of barrier to their learning or to them being able to understand their care plan. So cultural and language maybe barriers, social determinants of health that might be standing in the way. And are we really identifying the patient's goal from their perspective of what matters most to them? And so that's what we're going to talk about right now. But one thing I do want to emphasize, and I actually have it bolded and highlighted down here at the bottom, P-CHIPs are for patients that you identify in your practice as high risk. Not all patients in your practice require a P-CHIP for our standards. You'll have a policy that outlines here are the patients that we've identified that need a care plan. And that could be only our chronic care management patients need a care plan. Only patients that have been diagnosed with diabetes in the last 12 months need a care plan. Only patients that have been referred to a care coordinator through the provider need a P-CHIP. So you get the point, but not every patient in the practice. I kind of had a little meltdown the first time I was reading the standards because I thought, how are we going to have a P-CHIP on every single patient in the practice? Well, breathe easy. That's not a requirement. But again, back to identifying goals, working with patients, it's not, patients' goals should not be what we think they should be. It's not our goals. It should be what matters most to the patient. And it should be kind of a translation. So maybe we have a patient that has a diabetic A1C of 11, right? And that's way too high. We need to get that A1C down. So the goal for us in our mind was for the patient to have an A1C of 7, right? Or 9. Well, how does that translate to the patient? Maybe the patient is drinking 3 sweet teas a day and we need to get, maybe their goal should be 1 sweet tea a day. Maybe their goal isn't even regarding their chronic condition. Maybe it is their livelihood. I want to be able to walk my granddaughter down the aisle or run a 5K or play with my grandkids, whatever that looks like. Let's find a technique to interview those patients, and that's when they're going to become engaged and more interactive and compliant. I hate to use the word compliant, adherent, or excited actually about their care plan. PCMH 3.0. So moving on, this is about patient education. What we want here, we want the patient to walk into every visit and leave a little bit smarter than when they arrived. So are you providing patient education? This does not have to be, for our standards, it doesn't have to be anything that is generated from your EMR. It could be a pamphlet regarding smoking cessation, or I've actually got a really great example right here. Just something about your diabetes, having education about that, new prescription education, that type of thing. We all understand what it means to educate patients. In fact, I bet 80% of our job in healthcare is educating patients on either their acute conditions or their chronic conditions. So I don't think this one is a very difficult one to meet, but there does have to be proof of that education at that visit in the documentation. So number 4 is all about advanced access and community resources. Remember at the beginning, I started talking about a bigger concept. The concept really truly is to improve those outcomes, to reduce high utilization of ER and hospital visits. So keeping those chronic conditions under control, avoiding exacerbations and hospitalizations. That's what specifically this advanced access standard is about. So offering same-day appointments for urgent illnesses so that they're not utilizing the ER, having expanded weekday or evening or even occasionally maybe a Saturday clinic. We don't really set the requirements here. We just want to know that you do offer appointments somewhere outside of that typical Monday through Friday, 8 to 5. So maybe you're open one afternoon until 6 o'clock, maybe two days a month, you're open until 6 p.m. Or maybe you have a day a week where you're open at 7:30 a.m. Or like I said, maybe a Saturday clinic once a month, whatever works best that you feel like meets the needs for your patients. And then call coverage for when the office is closed. So how does the patient access their provider or a provider that's on call for them? How do they access information about their healthcare when your clinic is closed? So that could mean an after hours call service, a triage line. But really the big thing is that when they call, whoever they call, that person has to have access to their medical records so that they can advise them appropriately without creating more complications. This is just another example of meeting the needs when, after hours or not typical hours. So just examples: Monday through Friday, open 7 to 6, Friday open 7 to 4, and then maybe a Saturday clinic. Another thing that we want to know is that you are talking to your patients about a patient-centered medical home. What does it mean to them? Why is this important to them? What is a patient-centered medical home, and how does it benefit me as a patient? So, we really encourage brochures at check-in or posters hanging in the clinic. I think this is such a cool, and this is actually a clinic in Indiana. I think this is such a cool example of a flyer that is given. So it is our honor to take care of our patients so we've designed our healthcare system the way it should be. They're a PCMH, they provide coordinated care, after hours. Here's how to contact us after hours. They're at the bottom right. So this is just a really great example of a way that you can educate your community and your providers. A really great marketing tool as well. If anyone has questions about any of this stuff, Allie or Carolyn, if you guys wouldn't mind to let me know. The way that I have my screen set up right now, I actually can't see the chat. So feel free to chime in if you've got questions or comments. I would love to hear how maybe your practices are handling some of these, I don't want to say challenges, but some of these standards. So we will move on. But like I said, if there's anything that you would like to interject, please feel free to do so. PCMH 5.0 talks about how the organization provides patient follow-up. So this is follow-up for missed appointments or maybe requests for medication refills, high-risk medications in the home, lab or diagnostic results, that type of thing. Proactive management and follow-up of high-risk patients is proven to impact their compliance and their satisfaction, right? So checking in on them makes such a big difference in their life. I remember my mom she participated in a chronic care management program. So she had a CCM care coordinator that would call and check on her once a month, or every once in a while she'd actually do a home visit. And my mom began a friendship with this woman, with this nurse. And it was so great to watch her light up. She loved to talk to her nurse. Her name was Maggie. And so there was a behavioral health component to this as well, to that care coordination and that patient follow-up. And she always just thought, isn't that so nice of Maggie to call and check on me? So it really does, it engages the patient. PCMH 6.0 talks about quality improvement. We really support the PDSA model, but there's a lot of models out there that have the same components as PDSA, the Plan, Do, Study, Act. What we want to know is that you as a clinic are engaging your staff and your providers and looking and evaluating, hey, you know what, we could really improve some of the things we're doing, and making the efforts to make those improvements. So measuring your baseline, developing a plan to improve, setting a goal to where you want to end up, implementing those tasks or that plan, and then remeasuring at the end of that quarter and saying, you know what, we really did make that needle move, and engaging the staff. Maybe have a brag board and talk about it. But what we want to know is at least quarterly, you are looking for an opportunity to make some improvements within your practice. This could be anything from your no-call, no-show rates, improving that, to all the way up into the big NQF or ECQM measures like diabetic A1Cs or hypertension improvement, things like that. This is an example of a worksheet that we developed. It's a template that's available if you are one of our patient-centered medical home clinics. And it's just a one-page. It's a great worksheet to identify what your indicator or the measure you want to work on, your baseline. Where are you? Obviously, that's going to be in the dumpster because that's why you chose this measure to work on. And then what goal do you have? What percentage you want to end up at the end of that quarter? Why is this important? This is a big key because it gets your staff involved. Involve your staff in these things. It should not just be administrators and managers doing these QAPI or PDSA, these measure improvement type initiatives, and include the staff. They get very excited whenever they get to see that they've made a difference. So that's just a little worksheet that's available. PCMH 7.0 talks about patient health records and the completeness. So a lot of you, this is going to be very familiar for a lot of you because with your RHC accreditation or certification, I'm sure that you have to do some chart reviews. There are several components that we look at whenever we come for your PCMH survey, which actually does happen on site. We come for your initial survey and we get to actually talk to you about all the great things you're doing in your clinic. And then we're going to look at 10 charts per practice. And this is just, I believe that Allie said you all will be getting the recording of this and the slides. So I'll make sure she has access to that, to the slide deck. But these are the components of the chart that we look at. Obviously, a consent to treat per your policy. We want to make sure that that is executed appropriately. Are you evaluating and documenting a preferred language for the patient? Are you asking them what pharmacy they use? This is not just for e-prescribe. This is so you can have that care coordination piece with the pharmacy. Oh, I see that that Mary gets her prescriptions filled at Bob's Pharmacy. Let me call and make sure that she's A, picked up her prescription, and B, let's make sure that she's picking it up and talk to her and make sure she understands how to take it. If she can't pick it up, can we help provide maybe a transportation option for her, a resource for her? So that's one of the things that we look at. The darker blue ones are the ones, I'll just be very, very transparent. The darker blue are the ones that are that we see some deficiencies, a couple every once in a while. So advanced directive, making sure that you're addressing those, doing cognitive screenings, behavioral health screenings, a needs assessment. We'll talk about the needs assessment just a little bit more in the next standard. So I won't read all of these to you and go through all of these, but this is the exact checklist that our surveyors use whenever we do your chart reviews on site. I don't like chart reviews. I like to say record review, or I just think the chart audits and chart review sounds so harsh. So PCMH 8.0 talks about SDOHs, so social determinants of health and health equity. And what you're looking at is actually a screener that we've come up with and designed that actually meets several of our standards. So, but the big one that I want to talk about right now is truly the PCMH 8.0, where you are gathering information upon intake about maybe any kind of cultural differences that might create some health equity or some barriers, some issues with communication. Are we considering age? Are we considering a level of education, that type of thing in the practice? And then are we evaluating for needs, and not just physical health needs, as you see there? There's physical health, mental health concerns, personal concerns, and this is where we really fit in the social determinants. So access to nutritious foods, family issues, housing, inability to maybe pay bills or even manage chronic conditions. So what kind of concerns is the patient having? And then this is also a great place to start that conversation about goal setting. What kind of goals do you have? I know that when you just out of nowhere ask a patient, what are your goals? then they sometimes look like deer in headlights. I have no idea what my goals are. I have no idea. So this is just some ideas to get their wheels turning. But then at the top, as we talked about a little bit before, we want you to be talking to your patients about what is a patient-centered medical home. So this is just a little blurb that we've included. You're the most important member of your healthcare team. We want to meet your goals and needs. We know that health is not achieved in a clinic, but rather built in our homes, schools, workplaces, and communities. Help us get to know you and your healthcare needs by completing the form below. So again, what matters most to you? Let's talk. Is it your grandkids? Is it your dogs? Is it your, you don't want to lose your foot to osteomyelitis, or what's the most important thing to you? And then do you have an advanced directive? Yes or no? And if not, are you interested in obtaining one? So these are all really great questions. And I personally saw that, and I'm thinking even from a patient perspective, my own patient perspective, I would much rather, I think I would be more honest about some of these concerns by filling out this self-assessment, as opposed to maybe a nurse in the clinic sitting down and reading them like a questionnaire, worried about how people might perceive my answers or judge me based on a lot of the things that I may not want to say out loud, So this is a great tool as well. So those were the 8 standards that are specific to patient-centered medical home. So if you guys have any questions about that, the process is very simple. The way that the process looks is, if you are interested in becoming a patient-centered medical home, I'd love to take a call. We could, shoot some information through email, whatever that looks like. So if you need to get more information to present to leadership, I would be happy to help you with that over a phone call or email. But the next step is we have a little application you would fill out, and then we get started on advisor calls. So there's 3 to 5 advisor calls depending on your needs. And then we come out once you guys say, hey, we're ready. I think we are ready to be surveyed. We actually come on site. And like I said, we get to hear you talk about all the great programs you've got going and all the great resources you're providing to your patients, and your patient satisfaction. So it's really a very beneficial time for you guys to talk about your clinic and let your staff boast about those types of things, but it's also a great educational moment. So we can provide, if there are any deficiencies or gaps in the standards, we're there to help you meet those by all means. We're not there with a white glove. So I'm sure you've been able to kind of see, as I've gone through through all of the standards with you, the benefits to the patient. So having those same day appointment, convenience is really where it's at right now. Let's just kind of even examine our own lives. I know that if I can't get into my primary care provider, I'm going to go to urgent care down the street. So we have to be able to accommodate patients to an extent, right? Of course, we can't accommodate their every needs, but having those urgent appointments available and those walk-in appointments available, that is a benefit to the staff. Special plan to handle all types of patient communication. So by having different languages available in the documentation, and not the documentation, but the education that you're providing patients, that after hours service is available for patient-centered medical home patients. You have a team-based approach. So you have more than just your PCP and that nurse on that team. There's lots of people on the team to help coordinate that care. So there's lots of different benefits to the patient, obviously. Staff satisfaction. I can firsthand say that I got to watch our staff freak out, flip out whenever we said we were doing this and they started reading through the standards. They did not, this is too much work. How are we going to do this? We're already so busy. But once we actually got into the model and implemented it, we got to see staff satisfaction just multiply. It was beautiful because everyone is engaged. They understand the why. They're seeing the improved outcomes, and the relationships that you're building is so rewarding. And we all know that those relationships are truly what heal people. It's not the transactions that we make, it's the relationships that we build. So it improves staff satisfaction. That's why we got into it. So I saw it firsthand, and it's hard to believe at first, but it really is a great model to implement within your staff. Obviously, there's also benefits to the practice. Payers are recognizing this accreditation and this recognition, and they are paying for it because why? Lower cost and improved outcomes is what we're seeing with this model. PCMH is the foundation for our value-based payment future. It's what's happening. It's the model we're going to. So it's important we start to put the focus a little bit away from the volume and more into the, like I said, the relationships and the outcomes and the quality. So I want to read this. I know it's not fun to sit and listen to somebody read from a slide, but this is a testimonial. So being an accredited patient-centered medical home has put the patient at the very core of our practices. While seeing our patients, we have improved workflows to look at all aspects of the patient's health, not just their chief complaint for that visit. We're ensuring that they have established goals, have enhanced after-hours access to their healthcare providers, are closing their open care gap opportunities, and that they are receiving the best quality of care. Since being accredited, we've noticed that our quality scores have increased and patient satisfaction has increased as well. I think that was a very inclusive statement that she made. So here are some takeaways, and this is, I'm not here to tell you how to run your practice, but these were some really, really impactful things that I saw in our practices, not only from a financial standpoint and a quality improvement, but again, that patient and staff satisfaction perspective. So that patient-centered medical home is the foundation. I would say if you're going to start somewhere, start there. Once you are a patient-centered medical home, chronic care management, if you are not billing chronic care management services, you are missing out on a golden nugget. It is such a great program because the patients benefit from it so much. But currently in 2023, actually just got a raise. It is $77.94 per patient per month for 20 minutes of time that you spend, and you're probably already doing that work. So for your Medicare patients, you're able to bill a G0511 code and collect $77.94. So if you wanted me to do the math for you, that's about $4,000 for 50 patients a month. So hey, there's you a care coordinator right there. It's a great place to go. If you are doing chronic care management, then you're most likely ready to become a patient-centered medical home. So they work hand in hand both ways. Like I said, if you're doing one, you're ready for the other. The next one is participating in payer incentive programs. If you are not meeting with your payers, I would suggest determining who your largest payer is. So in our practices, we saw a lot of Humana patients. So we would meet with our Humana rep once a month, and then we got to where it was just once a quarter. But we would talk about of your patients who have open care gaps. What are the incentive programs that we can participate in? There's lots of low-hanging fruit out there with incentive programs that if you are improving quality with their beneficiaries, they're going to pay you for it. So meet with those payers. It is an extra task and it can seem like another pain point, but it will pay off in the long run. If you're not measuring quality improvement, I suggest doing it. I would suggest starting that today. And I'd be happy to talk to you about some different tools that are available out there. But just, and again, they don't have to be the large NQF measures and the big quality improvement stuff. It could be as small as whatever's important to your clinic, as collecting copays. Maybe you're not collecting the copays you need to. Again, the no-call, no-show rates. Maybe your hypertension is high in the clinic. So are your staff rechecking blood pressures? So whatever you feel is important for your population, then just look at one little nugget at a time. When you focus on one thing as opposed to trying to accomplish the whole world at once, when you focus on that one task and that one measure, it's amazing the impact you can make on that and move those needles. Huddles, I think you've all heard that I really like the huddle. So I would love to hear your stories, I call them glory stories, and about huddles and any great tips that you have that you've implemented in your clinics for for getting those huddles done. If you have any great checklists or sheets that you use, I'd love to hear it. I created one. I think it was the acronym for brush and floss. Did you brush and floss? And so each, the BRU, it reminded us to talk about something for that day. And then wellness visits. This is a big push. So I'm sure that if any of you out there are participating in an ACO, that wellness visits is a focus for you. I'm almost certain of that. So not all the work in a wellness visit has to be done by the provider. A lot of the screenings and the questionnaires, there's a lot of questionnaires involved in the wellness visit, can be done by your nursing staff. This is also a really great opportunity to capture all of those stragglers, like, is the patient, do they need a mammogram? Have they had a depression screening yet? So let's get that depression screening. Are we looking at their cognitive health and screening for any changes in that to detect Alzheimer's or any kind of dementia? So wellness visits can seem like a burden, but if you use them wisely and efficiently, they can actually make the rest of the year for that patient much simpler, where you are not having to focus on the referrals for all of the preventative care and things like that. So wellness visits it's a buzz term right now. And I know that you can't bill for, because of the all-inclusive rate, you can't bill for a wellness visit and a sick visit all at the same time. But encouraging that patient to come in for that wellness visit. You can also, just as a tip, if you have a wellness visit scheduled and the patient comes in and they still want to talk about maybe their high blood pressure or some back pain, that's okay. You can still have a wellness visit as long as they feel like doing all the other screeners and everything else that's included. You can talk about an acute issue or maybe a medication refill, because really what a wellness visit focuses on is managing your chronic conditions. So if any of those issues that they're having and that they want to talk about at that visit can be tied back to those chronic conditions, then that's absolutely acceptable. This is just a brief look at the different accreditations and certifications that the compliance team can help you with if you're interested. We have lots of different things out there available, and that doesn't even list all of them. But I do like Sandy's quote here, our CEO: simplification leads to clarity, and clarity allows the provider to focus on improving everyday services to their patients and their own bottom lines. So with our standards, you aren't trying to decipher, what does this really mean? You're not trying to interpret, okay, what do they really mean here? They are simplified. If you don't understand them, there's somebody at the other end of an email or a phone call. They can interpret that for you. We are not here to confuse you or make it, we love perfect surveys. So whatever we can do to help you with perfect surveys, either for your rural health clinic accreditation or for PCMH, we'd be happy to help. Here is my contact information. This is actually my cell phone number there at the bottom in red, 417-631-2942. That actually rings to my office and to my cell phone. So I would be happy to take any questions. My email address is KOGDEN, so K Ogden at thecomplianceteam.org. And if there's any questions I can answer for you all now, or anything that you would like to share with me, I would love to hear those. Otherwise, if you want to just shoot me an email and we can schedule a one-on-one call, or correspond through email, whatever is best for you. But I'm so honored to have been here to speak to you guys today. And again, I hope the weather doesn't cause too much turmoil for everyone. And I'm hoping to give you just a little bit of time left back in your lunch break. So Allie, Carolyn, are there any questions? Is there anything else that you would like for me to cover regarding PCMH?
Kristen, we haven't had any questions come in yet. We'll give everybody just a few more minutes to submit those if they have any. I think that it was a pretty comprehensive coverage there of all those points and all the requirements. So I don't have any questions myself. As I said, we'll leave it open another minute or two for anyone to submit anything, but we just really appreciate your time today. Again, the comprehensive nature of your presentation, and yeah, just really appreciate you being willing to share with us.
Of course, I'm happy to do it anytime. And if you guys have questions, like I said, regarding rural health clinic accreditation, Kate and Kate is the queen of rural health clinic accreditation and all that knowledge. But she and I can help with RHC or PCMH, however is needed. So I'd be happy to speak to any of you. Thanks for having me again, both of you.
Thank you. Everyone have a wonderful day.
Thank you. Bye-bye.